Jack Jallo. I'm a neurosurgeon at Thomas Jefferson University Hospital, and today we'll be discussing anterior versus posterior cervical spine surgery with some of my partners.
Hi, my name is Srinivas Prasad. I'm also a neurosurgeon at Thomas Jefferson. I also specialize just in complex spine surgery.
And I'm Josh Heller, again, also a neurosurgeon at Thomas Jefferson University, and we're going to be talking specifically about anterior versus posterior surgery in elderly patients and the complexity of that.
Thank you, Josh. So, one of the issues that very often occurs in elderly patients with cervical spondylosis or myelopathy, radiculopathy, is what's the best approach to address their symptomatology, taking into consideration their age, comorbidities, the adequacy of decompression, and then need for stabilization, as well as how do we approach that stabilization via an anterior or posterior approach. And Dr. Prasad, what are your initial thoughts?
Yeah, so generally I think clinically we encounter cervical radiculopathy and myelopathy primarily. And so I kind of think of those almost distinctly in defining what the goals of the surgery are going to be. And so for any given patient, I think I would define like, okay, here I think the foraminal stenosis is bad at say C4, 5, and 5, 6, the central stenosis at whatever levels as well, to kind of compose a surgical plan for them. But I think what's unique about the elderly patients is really the fact that they typically have multi-level cervical spondylotic changes. So it's not as common, certainly possible, we were talking about this earlier, to have single-level disease. But in the older people, I think adjacent segments are always a consideration, alignment is a consideration, swallowing function, voice issues, things like that are a function as well.
Yeah, I agree entirely. It's rare to find a patient who has single-level disease, but when you do, that patient still may benefit from an anterior approach. So we often, for all the reasons that Dr. Prasad just brought up, that we tend to go posteriorly more commonly in elderly patients, there is a rare patient that would have a reasonable choice to go for an anterior approach if they have a single level or two levels of pathology and otherwise relatively normal appearing neck. There is the other consideration, though, somebody who has multi-level disease in addition to kyphosis, and then trying to see, hey, do we need to do something that restores their alignment better, and is that risk of swallowing dysfunction and other problems associated with either anterior approach alone or anterior posterior approach, is it worth it?
What have you found? Yeah, it's a good point. I think the swallowing function thing is always a consideration that's kind of more of a concern in older people. What do you think, Jack? How do you think about swallowing function in the approaches? Like, what's been your experience with that?
So I think, swallowing function is a concern more in the elderly based on all of our experiences, although I think for a single or two-level, as was mentioned, where alignment is otherwise not an issue and you've got a disc herniations with spinal cord compression or root compression, I think an anterior approach is fairly well tolerated. I don't recall doing it in an individual over the age of 80, but certainly up to 80, I've certainly done anterior approaches in those individuals, and they've done well, and surprisingly have not had any swallowing difficulties afterwards. I think you do have to be attentive to the fact that the tissues are a little bit more redundant. Things are and either are more pliable than normal with tortuous vessels, or they can be stiffer with calcifications and less mobile. And I've experienced both, where you've got a trachea and esophagus that's more difficult to mobilize, or a carotid that's calcified and you need to factor in not manipulating that carotid for fear of inadvertently causing plaque to elevate and result in stroke. When it comes to multi-level disease, which again, many of these individuals who are older will have multi-level diseases, and then posterior approaches are less morbid for the individual. Ultimately, it's about what gives you that patient the best results. Keeping in mind that posterior approaches are generally associated with higher complications, right? I mean, we do a lot of anterior as well as posterior cervical spine surgery, and when we decide to go or choose, or for myself at least, when I choose a posterior approach for that individual, I'm factoring in for them the added complication rates associated with the posterior approach versus the known complications or my concerns for the adequacy of a decompression anteriorly when you've got multi-level disease, as well as the complications associated with that anterior approach. Primarily, again, it's that swallowing concern. How about
Do you have tricks for managing C3-4? I mean, like that seems like a spot that's much more precarious in older people.
Yeah, and I see more C3-4 pathology in older people for unclear reasons, and isolated C3-4, or I mean, just recently did a C2-3. I don't know that I have any particular tricks other than take your time with the exposure, and be gentle with the tissues that you're trying to manipulate.
What do you think that's a good trick? One thing I've noticed is in terms of central versus foraminal decompression, as I had mentioned, like for myelopathy, I think there's just no beating a posterior cervical laminectomy from a cord release and cord decompression perspective. What do you think about uncovertebral? You see so much more osteophytic disease in uncovertebral stuff. What do you think about your ability to do a good foraminal decompression from the front versus the back?
Yeah, so it is easier to get a good foraminal decompression from the front for sure. The issue, though, becomes that you're dealing with the patient that has multi-level cervical spondylosis. Most often they have myelopathy in addition to radiculopathy. The question is, how much is the radiculopathy symptoms affecting them? Do you really need to go for a wider foraminal decompression if you're doing a posterior approach, or is that risk associated with either having a nerve root injury or palsy afterwards worth it? And if you're going to do it, how do you want to do it? Do you want to do it with a microscope? Do you want to take the time to use drill only as opposed to potentially causing issues with kerosins and such? And so it's a really, I think the conversation has to be with the patient, hey, how much of that radicular symptoms are you really having, or is this more myelopathy?
That's a really good point. We do need to wrap up our discussion here. Just as a final question, what percentage of your patients are in the elderly population are you approaching them anteriorly versus posteriorly?
I would say that 80% are approached posteriorly, predominantly because of multi-levels of cervical spondylosis and stenosis and treatment of mostly myelopathy, and for all the fears of why we said, hey, to avoid an anterior approach with having large, bulky osteophytes, swallowing dysfunction already, and our tolerance to say, hey, we don't need to get perfect alignment, that these patients can tolerate as such. So a posterior cervical laminectomy infusion. Where we switch back and forth upon is how long are we going? So I know we've talked about this before, whether or not we should keep it to, like, say, C3 to 6 to minimize the time and potential risks of it, or are we doing longer crossing the cervicothoracic junction? I'm just going to throw it out there too that even in suboptimal alignment, laminoplasty is still an option if patients demonstrate they have relatively rigidity with their flexion extension x-rays, that maybe they're better served than going for a full decompression and fusion.
Dr. Prasad?
Yeah, I think I probably mirror that, honestly, maybe 70-75%. Again, it comes down to the number of levels that
Sure.
I think you're dealing with and what levels specifically. But I would definitely favor, I would say I do favor in my practice, posterior approach generally for the elderly for many of the same reasons.
Yeah, and I do as well. I mean, by and large, based on the age, multi-level involvement, posterior approaches tend to be the most appropriate. But keep in mind, anterior approaches to the elderly spine are available to you. They're well tolerated. It's just based on the nature of an aging population, less commonly encountered. I think a great topic for the future is the various options for posterior approaches.
Sure.
Thank you all for your attention.
Thank you.